Retrograde PCI is the latest and greatest thing in interventional cardiology right now. The high you get after crossing a lesion retrogradely is unmeasurable. I have with me Dr. Mehta from Jaslok Hospital, who's been practicing for over 50 years. I want to know his highs, his lows, where he got stuck, and learn from him and hopefully get better. Dr. Mehta, how are you
Hi,
doing?
Arasi. Pretty good. I'm so delighted to be with you. And when I see a young person, I get nostalgic. Wow, I've gone through the spectrum of cardiology in India, and then so happy to share my experience with you. Tell me.
So let's start with your first retrograde PCI case.
Let me start with my first angioplasty case. You know
Sure.
what? Very first, actually, till 1984, I was practicing clinical cardiology and invasive cardiology, but only up to angiography. And then our patients would go for surgery because nobody had seen the daylight of even angioplasty in India. And when I realized after Andreas Grunzig came to India at my invitation, and then I got curiously interested and also got enamored that, wow, what a simple way of treating a blocked artery. So then 88, we took our first plasty, but there was a little humor in that. Mine was a first plasty. The patient was a Brunal Gore's brother, and Brunal Gore was a social activist. And there was a big crowd outside and then the patient was nervous. He was almost into tears. So I asked him, why are you crying? He said, I'm so scared. It's my first angioplasty. So I admitted to him that mine first angioplasty too. I'm not crying, but okay. So that's how it began. And then I think you're right. I think the journey, I personally believe that the stress that the angioplaster or interventional cardiologist to undergo is far more than the coronary surgeon. The reason is this. You're worried about the social impact. If people consider that angioplasty is a simple procedure and if mishap takes place, they feel disgusted with you. Say, oh my God, what did you do? Just a plasty? But bypass is acceptable. Bypass, because the people already know that it is associated with some mortality. Yes. So that's it. Now, you asked me about my retrograde. But before that, I wanted to tell you that complexity, you uttered about complexity. It's ultimate in complexity. I agree with you. But you know what bothers me about complexity? Not the case, not its anatomical complexity, but its social status. If a patient in whom are doing angiography at medical college where I was professor for more than 30 years, if I'm doing an angiography or an angioplasty with them, the patient have full faith, their expectations are limited, consider me as a god. But if I'm doing an elite man in the
Private
Mumbai
setting.
in private hospital, and then I keep on getting phone calls from 1, 2, 3, 4 people. Is our friend, is this, etc. Dr. Mehta, take good care. I take good care of everybody. But when they say that, tension binds up. To give you an example, when JP was admitted, Jayaprakash Narayan was admitted in Jaslok Hospital, and then there used to be a phone call from PMO's office. PMO was Indira Gandhi, and she was very concerned about JP's health. And then I would develop tension. My God, I hope nothing goes wrong. I'll be on the front page of Times of India. And then, so those were things. Now, I didn't know about the retrograde much, to be honest with you. So when I got intrigued about the retrograde, and I thought, what is a Makkah? And this is Japan, is a Makkah. There are two centers, Nagoya and Kobe. And twice in a year, one time I'll go to Nagoya, the other time I'll go to Kobe. And both of them, marvelous. And the Japanese make me feel that there's nothing like undoable. They were so good and they're so focused. And then I learned my preliminaries of retrograde angioplasty there. And with me was Dr. Nicholas Reifert. And so I said, Nicholas, I don't have all these kinds of wires with me. He said, don't worry, Ashwin. Even do you have any polymer wire? I said, yeah, I've got Whisper. I said, it will work. Try that. And I picked up a very simple case, which I thought that I would easily do it and conquer it. And then we all got together, we thought, we planned, we designed, and then we collected hardwares and everything. And we put the patient and we did believe me, it was so successful that I thought I'm the king of now.
Yes, the
Retrograde.
high I was talking about. Yes.
I got very high about it, and I thought Japanese are nothing in front of me. But the second case, I had a septal hematoma,
Okay.
and this patient went into heart failure, and it was bulging on both sides. So even surgeons also said, Dr. Mehta, we do not know how to help you out, etc. Fortunately, we managed him, and then slowly over a period of time, the hematoma settled down, and then I very, very gently requested the patient that if you mind, we can do it again sometime. A colleague of mine is coming from Japan. He knows a lot more than me, and we take his help and we'll do it. He says, I'm fine without anything. And I don't want to go back into that torture again. So it does happen, that's it. And you said complexity. And actually, complexity is also the other thing is that over a period of time, when you repeatedly perform a procedure and then it starts becoming in a way a routine, the complexity gets converted into simplicity. And I feel the interventional cardiology is not a rocket science. And with perseverance, with focus, concentration, courage, and confidence, you can make it.
Absolutely.
Yeah.
Absolutely. I like it how you say interventional cardiology is not rocket science. I say, as interventional cardiologists, we are just glorified plumbers. Our plumbing system is the heart rather than the pipes of the houses.
A friend of mine told me a very humorous story, a joke, if you call it, like that. He said one day in America, a man has choked pipes, water pipes, and he called a plumber, and he said, fix it up. And then after fixing it up, he had brought some all kinds of instruments. He fixed it up, and he said, I'll charge you $500. He said, my God, I don't get paid that much. I'm an interventional cardiologist at Mount Sinai. I don't get paid that much. He says, I know it. I said, how do you know? Even I was interventional cardiologist.
So
just a
absolutely.
lighter side of it.
Yes.
So a glorified plumber, it's I think it's an oversimplification, but I think if you talk objectively, then I think when you are playing with the heart of somebody, and do you know that the worst possible complication can occur right in front of you, in front of your eyes, and that's demise. You may lose the case and the right to, and then half a dozen people are waiting outside eagerly to see their brother or sister, whosoever it is, their kin and kith, everybody, that he'll just move out, and Dr. Mehta will tell us that how nicely everything has happened. And I think so therefore, complexity involves also the just in case if you start indulging yourself to get challenging cases, challenging in terms of dire consequences. We are a patient who is hemodynamically compromised or a high risk situation in terms of morbidity and whatnot. I think you have to fairly prepare yourself and the family both.
Yes.
Yeah.
So, Dr. Mehta, I want to, I've always been curious about this. You would have seen so many firsts, right? The
Yes, I
first
did.
angioplasty, first rotational atherectomy, first antegrade or first retrograde CTO. I mean, how did you keep evolving? Why didn't you say this is enough? And why did you keep pushing yourself? What was your motivation?
Curiosity. My basic nature is predominated, my personality is predominated with curiosity in my mind at the highest level. Why? And you know how that also is an acquired character. Huh? Arasi, I must admit, it's not. I was not born curious, but what happened? Dr. Ramalinga Swami, the chairman of AIMS, and also he was a member of the Nobel Committee, Nobel Prize Committee. One day he was admitted in Jaslok Hospital with infeval infarction, and I had a casual chat with him. And I said, Rama, what is it that common you find or observe amongst all Nobel Prize winners? He said, Ashwin Mehta, two things: curiosity and persistence. They keep on going and going and on and on and on until they go to the bottom of it, until their curiosity is satisfied. I said, that's a nice thing to develop as a characteristics, I think. And it's enjoyable, believe me. When you develop a sense of curiosity, it's really enjoyable.
Absolutely.
Yeah.
Now let's get to some technical tricks and tips. Okay, tell us about a struggle in rotational atherectomy, like something which you haven't heard of, or no one has taught you that, and you got stuck with the burr somewhere, and some how you got yourself out of it.
You're right. I think stuck with the burr. I
Stuck
really
with the
got
burr.
stuck. There was one obese patient, 140, and he had a very distal, very heavily calcified bifurcation, PDA, PLB. I knew it's a very heavily calcified, and it's way away from the ostium. So first of all, I had to at least bring the platform to a level which is within the reach of the 6 centimeter that the burr can move. The the knob can advance to 6 centimeter. So the first day I thought that I will use a guide liner and then try and reach up to the platform. And I used a guide liner. And as my luck would have it, that guide liner also were facing tortuosity. The moment the balloon support I'll release from the guide liner also will flay out. So then I said, I tried, struggled for about an hour and a half, and then I said, I'll have to give up. So I said that, look, we have some more instruments to get from other parts of the country, and so we'll do it again 2 days later. The 2 days later, I decided that I'll take a 6 French guide catheter, soften it very well, and then over a balloon, I'll advance it and dip sit it as far as possible. It's fair enough. It came within the vicinity of about a couple of centimeters. Now said, I made it.
Okay.
Now I thought, now I've got it. And I was doing burring, and I started with 1.25, which I think I wish I had not. And it watermeloned. And it just
Went through.
watermelon seed, and it went through, and it wouldn't come out. And the patient's family was very well known to me, and I struggled, and then they pushed the guide catheter, cut the sheath, and the whole thing I was trying to push it back. And the patient started complaining of pain, and I said, now what to do? Then I went to the contralateral groin, and then I said that let me keep on put another ping pong, yeah, and do come in, and passed a small wires, like fine wires, like fine the I had the polymer wires, and then I went by the side, but it wouldn't come out. Ultimately, after struggle, I had to give it up. And then I said, I called surgeon. I said, Arun, please take him up. And I felt in a way nice also that Arun said, my God, I could not remove the burr on table.
Oh, wow.
It was so embedded in the calcium that I had to remove piecemeal by taking the cutting instruments and whatnot. And ultimately I dislodged it, and then I put a graft on that. But it took totally, I was throughout the procedure, I was with the patient because I was very concerned. I thought it's my doing, and I was feeling guilty about the whole thing. And the whole almost 12 hours I was with the patient on my toes, but ultimately went home. So in the life, many times you come across situations which are unanticipated but put you to a stress. And people say that you must learn how to conquer stress and how to conquer complexities and all. Easier said than done, Arasi.
Yes,
Huh?
I agree
Isn't
with
it?
you. I agree with you, yes.
And I see you're a young cardiologist. Young, I think you have enough experience, although I can't call you young, but still, as compared to me, you're still a long journey ahead of you.
Yes.
So I'm sure you'll also come across many stories which will stick to your mind.
Sure,
yeah,
absolutely.
yeah.
Now let's go to retrograde PCIs. You said, the first case you did with the whisper wire, etc. And the wire choices have obviously gone up and expanded. So what is your favorite 1, 2, 3 wires for retrograde?
Okay.
Septal, epicardial.
Right. First of all, I very carefully study the septal collaterals because they are comparatively safe. And Werner is a good friend of mine. Gerald Werner.
Yes.
He's a good friend of mine. And, so sometimes when I informally chat with him during the lunch hours, in the meetings, etc., and I'm impressed by he and Marumatsu. They said that, Ashwin, if you see tortuosity and if there is a thin but it's straight one, prefer a straight one. So slowly I learned how to serve, then slowly I learned how to select the right kind of a septal channel. And currently my favorite wire, if you honestly ask me, is a little different. Like I use cyan black. Cyan black.
Cyan black,
And
yes.
the only disadvantage is that it keeps on entering all the
Teeny
small
tiny
branches.
True.
Yeah.
Yes.
But yeah, I think it gives you a higher rate of success to cross the.
That's my favorite one too.
Really?
Yes.
Wow. Okay. So that's where we agree, I think. And cyan black. And currently, my micro catheter is Corsair Pro XS.
Okay. Okay.
Now the XS has reached India. You got them?
We have them. We've
Corsair
used them.
Pro
Yes,
XS? Yeah.
yes. So I've used all of them, but my favorite is a Turnpike LP sometimes, or the Corsair Pro XS, both of them, and sometimes the Mamba Flex. I don't think you've used the Mambas here. They are very good.
Neither Turnpike.
Oh,
It hasn't reached Indian shore.
See, the Mamba is kind of very hydrophilic. So if you have a jailed septal with a stent, you can, cross it without dilating the stent struts. That's the advantage. But I think Corsair Pro XS was also like that, right? It can.
Yeah. Of late, I think that's the best one.
Okay.
Many more may come in future.
So have you had a situation where you've gone all across, but this microcatheter will not go and is being a stubborn son of a gun? What is your backup catheter?
No, it has happened. It has happened. Then, surprisingly, as we saw today morning, that in a situation, there was one Arab gentleman. We keep on getting patients from Middle East, and he was a very tough guy, very good high tolerance to pain, and I attempted first retrograde, and it went all the way, but it got stuck. But it was some nasty plaque in the distal sec. Yeah, so that I gave up, and then I went into the antegrade. And antegrade, it went into the false passage. So I said, let me try a parallel wire technique. So then I went by parallel wire technique, and that also went into the false passage. So I said, there's no point in keeping two parallel wires there. So then ultimately, to my surprise, I said, let me try Conquest. And I generally don't prefer Conquest straight away, because it's not very torqueable.
Yes.
It's stiff wire. And to my luck, it went through, and it became. In fact, I had offered him that if, look, I have failed, and if you wish that you want to go to Japan, there are more experts there. You can go there. He said, no, Dr. Mehta, I want to stay with you. I'm sure you'll be successful. Try once more. So if the patient is with you, Arasi, then you're very comfortable. To deliver your best, you need patient's confidence in you.
Dr. Mehta, what I've kind of been seeing repeatedly, you are all about the forest, the patient. You're not getting hung up on the case and making the case successful. You repeatedly are bringing the focus back to the patient. And I think that's a very important message for anyone who sees this.
Well, I think so. And I think it comes from basically every now and then when you do a case and you realize with some compassion that there are people eagerly waiting, the patient's kids and all, everybody, and that things makes you responsible, that deliver nothing else but your best.
Sure.
And focus and deliver your best, and then hope for the best.
Thank you so much, Dr. Mehta. It has been a pleasure. The message I'm going to take from here is stay curious and stay persistent. Thank you very much.
Thank you, Arasi. Nice talking to you.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.